Please give a warm round of applause for Mike Cloutier.
Well, good evening, everyone. And Nick, thank you very much for the opportunity to be here this evening. As Nick said, I have spent nearly 50 years of my life in life sciences and health. So I'm just happy to be really anywhere most nights, but tonight's particularly special. I have a less than traditional background story in getting into healthcare. I didn't begin with any kind of vision to be involved in healthcare or life sciences. I attended and that background story is important because as Nick alluded, this concept of a outsider coming to an insider and then an insider having to think about things as an outsider became very important to me over time. But it began honestly because when I first of all, I don't have a degree. I didn't go to a university. I went to a tremendous educational place called Sheridan College. I'm a community college graduate. And when I got out of school, I was working as a salesperson in industrial sales, going into factories and selling safety equipment. And it became evident to me that as much as I was enjoying this work financially, and it was very rewarding in terms of my capabilities as a salesperson, there was something significantly missing. And I wanted to do something that I could bring my skills and my knowledge to that would perhaps have a lot more meaning. And I was living at home. I was getting married later in the year, and I was living at home, and I was having dinner with my mom that evening, and I said, I'm getting a little frustrated with this work, and I'm really looking for something different. And she said to me, you should think about maybe being a detail man. And I said, what's a detail man? I'm not very detailed at all. And she said, well, these people come by. She worked for a urologist. She was a receptionist. She said, these people come by and they sell pharmaceutical products. And I thought, oh, that's interesting. I mean, that sounds like something far more rewarding. But for a person who hadn't taken science in high school, because I was the beneficiary of a high school that decided to be okay if we just took courses we wanted instead of what we needed. And what I wanted was to do very little, and I wanted to study math. And so that's what I did. I didn't do science. And so I'm sitting there thinking to myself, I don't have a degree. I don't know anything about science, but, and my mother's telling me, oh, this would be a great job. And I applied for a job, and at the intersection of hard work and luck, I was given an opportunity to work for a company called Searle. So that's how it began for me. I started out in this life sciences world in healthcare as a sales representative for a drug company. So why do I tell the backstory? Because my views are really based in life experience. They're not theoretical. I mean, I live these things, and my observations, they're not imagined. They're not theory. They're the practical examples that I lived in, observed, and was a part of over that career. Which brings me to the second part of that, the underpinning of my views. I said earlier, and Nick alluded to it as well, I really was an outsider. I mean, you're an outsider even when you're in pharma. Because most of the healthcare sector doesn't really want a lot to do with you because of your perceived motivations. But beyond that, most of everything, I was an outsider, and I was looking to become an insider. And so that's the work I began. I started choosing to try and understand the system from a delivery perspective in the best way I could, and that was to volunteer my services, primarily my business acumen, my capability in problem solving and things that I had learned practically on the street or through the great people at Sheridan College, to try and give back. So I looked for those opportunities. I was recruited into the board of directors for a community-based nursing health organization. I applied and was able to join the board of directors for Joseph Brand Hospital. I got involved with patient associations. I got involved with physician associations and part of the Canadian Medical Association at one point during my career. And I chose to do all of those things because I wanted to be an outsider who could become an insider through a practical lens of seeing how healthcare gets delivered by being part of what those people do, at least conceptually in the process. Now, I'm not a doctor, I'm not a pharmacist, so I've never practiced medicine or delivered it, but I've been at those tables with people who are making decisions and who are formulating ideas that could become practical in the system. And so if I was going to go out there and bring the pharmaceutical opportunities and the products that we made available, I wanted to understand this holistically. I wanted to know where we fit and how we could help, but I wanted to understand the system on a broader level. And so really, for me, that's where it all started. And I do fundamentally believe that we have a system that is very much fragmented and broken, and that's the work that we need to address. So underpinning all of that for me is a core belief that universality, despite Tommy Douglas's best efforts, really doesn't exist. It's really a lie that we as Canadians tell ourselves. And in fact, we're actually kind of proud of the fact that we talk about universality, but it's kind of shameful to the previous point that we don't have it. We are still living in a very fragmented system, as the other speakers have already alluded to, and that access really depends on a lot of things that aren't really based in where good care should come from. It's about demography and geography. It's about financial means. It's about a lot of things that aren't fair, just, and equitable. And so for me, if we're going to begin with a conversation about the basic tenets of reform and how we go about that, we need to be honest and address those things head on. We need to recognize that this system that is in crisis is primarily driven, unfortunately, by a lot of theory. It's politicized, and it isn't really available in a meaningful way to the people when they really need it. And so I have 3 ideas I want to share, 3 design concepts and choices for you this evening that really, I hope, deal with equity, access, and outcomes. So design choice number 1 that I would put forward is that there is automatic attachment to care, that every Canadian is connected to a care home, whether that be physical bricks and mortar or a combination of physical bricks, mortar, and virtual care. That every Canadian, and it was mentioned earlier that a vast majority, 7 million, I think the number was, of Canadians who don't have access to a physician. And this care center is really about making sure that all of the care providers in the system are coordinated in their approach to care, so much along the same lines as our taking personal ownership of that, but we have a team that's dedicated to us as patients, as the consumers of care, including physicians and pharmacists and nurse practitioners, mental health specialists, and social support specialists that are available to us. And that the standards of the care that are provided really are surrounded by rapid access, easy access, emergency access, and really a seamless reattachment in and out of the system as we need it, both in the acute and chronic stages. And that really this community care, primary care home, physical and virtual, is there really to provide us with a starting point, but also to ensure the continuity of care as we go. The second design choice is really around target care navigation. It's really about there being a navigator who's there for us and coordinates our care. And this is not bureaucracy. This is not an individual who's there to create more systems issues, but rather is someone who will assist us because we are so poorly educated about the system that we really don't understand healthcare and the delivery of healthcare until we're unfortunately in it, usually in an acute way and usually in a very complex, serious way. And so the idea is for us to have a navigator who works with us to ensure that whether it be an acute complex need or an acute disease situation, whether it be a chronic condition that we're living with, that they're really there to help us migrate and understand and migrate through and understand the complexities of the system, and how to get our care. So hand in hand with that community access. It's a data-driven world, and we need someone to help us with the data. And I love the point of us owning our own data and us being the purveyors of that data to others. Also, that we need to ensure that we're working on looking at a system that's about impact rather than cost, and really looking at value creation. The third choice and tenet is really around outcomes-based funding. So right now, it occurs to me through my experience, observed and having been in the system as a user, that too much of what's provided is based purely on volume and the association of care related to volume. And so going after the biggest problems, regardless of what the problems are in the acute need individual setting. Funding really should follow personal need, population need, and complexity, data-driven, clean data, functional data, which is a big problem. And that needs to be available to us to really ensure that the care we get is the best care we can get. And so we need to incent prevention as a starting point. We need to incent coordination and measurable results. And so that, that's the way funding should occur. It should occur on the basis of achievement and providing better results, and in a very quantitative way. And the system, this shift from, volume to value, I think, is one that is very easily arrived at once you change the way we go about things and the perspective that we have, which is really about, and it's been said already twice, and I'm sure it'll be said again, it starts with patients. It starts with caregivers. They are the epicenter. And if we begin there, we can build out on their basis, our basis. So I started with an origin story, and I'll start with a conclusion story. And it's really, so I'm sure a lot of people would wonder why an individual who's had a great career, it's been financially rewarding, it's been spiritually rewarding, and at this point in my life, I probably should be spending a lot more time playing golf and pickleball and hanging out with my grandchildren. And I try to do as much of that as I can. But at the end of the day, I still feel very vital in this system. I'm still very active in the system related to a lot of the investments I make, a lot of the advisory work I get to do and I'm invited to do. And quite frankly, by being able to really augment messages that good people have about how this can be better. And I do that because of the very people that I don't get to spend as much time with as I wish. Those great grandchildren that I have, my own kids, my friends, and my family. This system needs a lot of work, and it needs all of us to be a part of the solution. And so I firmly believe that, my work is not done in that regard, and I want to continue to do so. So I take the perspective of now being somewhat of an insider, but not completely, and remembering all the people who are on the outside who really don't understand what's going on and really need our help in building a new and better way for them while we bring them in, to the system, and they become insiders and can be advocates for their own health and their own prosperity. So thanks very much for the opportunity once again. Enjoy the evening.